Before the blue dye can be applied to the nail, it's important that we thin the nail down as much as possible. This is painless. We use a burr to do this. We use a blue dye to make the fungal cells sensitive to light. Fungal cells are different to human cells because they have a cell wall. A special blue dye that we put on makes them sensitive to light, which causes the cell walls to break down. And this is what destroys the fungal cells, but is completely harmless to the human cells. So the blue dye we place on the nail is quite intense in colour, and it needs to be left on for about 10 minutes to any of the affected nails. Once this has had a chance to stain the fungal cells, we can then apply the light. And the light will be applied for 9.5 minutes for each nail. Once the blue dye has been left on for 10 minutes, we can then use the light from the PACT unit. And this introduces light to the subject at a particular frequency. And it's 9.5 minutes we apply it for. It's painless and it's completely harmless to human cells as well. But these sensitised fungal cells will now react to the light. It gets placed over the nail. And now it's just a case of being patient and waiting. This process is repeated 3 times in the first week. It's important that it happens 3 times in the first week to get the most benefit from the treatment. And then after 3 months' time we can review again, at which point hopefully the nail will be showing signs of clear, healthy regrowth at the base of the nail. More severe cases of fungal nail infection may require monthly treatments, and you'd be looking for about 6 months for resolution. So that's the first treatment completed. We'll have 2 more treatments this week for the first cycle, and then we'll review this nail again in 3 months' time. So, quick, painless procedure.
High heels are the fashion staple of every woman's wardrobe, so it's not surprising to see women strutting in sky-high stilettos on a night out. But these shoes are called killer heels for a reason, as 25-year-old Paris found out on a night out with her friends.
As I was rushing, wasn't really concentrating on the path ahead of me. The bitumen was uneven and I'd just fallen straight off my heel and straight onto my ankle.
According to Monash University, 258 people have gone to emergency departments with high heel related injuries in the past 5 years.
I had a severely sprained ankle and tore my lateral ligaments and a couple of muscles in my ankle. So it was pretty painful and a long road to recovery. I had to wear a moon boot for a month or so, and then constant physiotherapy and exercises to try and strengthen the muscles.
The height of heels has increased dramatically in recent years, with some now reaching a staggering 17 centimetres. The average height of a heel is 11 centimetres, more than double what it was in the 70s. The Australian Podiatry Association's Nick Lange says heels throw a woman's weight forward and dramatically increase the risk of overbalancing.
Women don't realise the effects that the high heels are having. As soon as we go up in height onto a high heel, you're moving the body's centre of mass further forward onto the metatarsal area, or the ball of the foot area, and that puts a lot of pressure in that area. So those pressures can in fact double for every inch that we go up in heel height.
Experts say it's easy to link high heel-related injuries with alcohol consumption.
Well, I certainly think it is a dangerous combination because of maybe the lack of concentration when we are walking. If you're going to wear a high heel, try and alternate the height of the high heel.
He believes that despite the risk for serious injury, wearing heels is the cultural norm and isn't likely to change.
I think fashion comes first with women a lot of the time. Obviously a flat shoe is the best, but if, as a compromise, probably the wedge shoe is going to be more safe, more secure than the stiletto shoe.
Young women, probably women of all ages, feel powerful and feminine when they are wearing heels.
It seems they say the higher you are, the harder you fall, for a reason.
Do you know that our feet were designed to function on soft, natural surfaces such as grass, soil and sand? Yet most of us spend the majority of our time in unsupportive shoes, walking on hard, flat, unnatural surfaces. Hi, I'm Philip Vasili, and I've spent over 30 years as a podiatrist specialising in biomechanics. I've treated thousands of patients, and I've found that these hard, flat surfaces cause our feet to roll in too far or overpronate. This excessive pronation can be the cause of many common aches and pains, such as plantar fasciitis or heel pain, knee pain, and even back pain. Now I'm going to talk to you about excess pronation, what it is, and its effect on our body. Now look at the line on Aaron's leg. Excessive pronation is the rolling inwards of the feet. As you can see here, the foot rolls inwards, causing a flattening and elongation of the arch, which results in a chain reaction of misalignment up the leg. You can also see how the collapsing of the arch can affect the length of her foot. Now look at the line drawn on Aaron's foot in the pronated position and compare it to the neutral or the correct position. You can see the difference in the length of her foot. Now people often think their feet are getting longer, but in fact their feet are actually collapsing, making the foot appear longer, and you can even see the difference in her arch. By placing the orthotic device under her foot, now you can see a dramatic difference from the inside and then from the front in the alignment of the foot, the leg, and even the knee. Orthoheel orthotic technology lifts the arch and helps support and realign the feet, which often provides relief from these common aches and pains associated with overpronation. This technology is available in our orthotics and is built right into all of our footwear. With Orthoheel technology, we're giving you back your footprint, and in doing so, your ability to live the life you want to live in comfort.
Now, live, NBC 10 News at 11.
On the NBC 10 Health Watch at 11, if you've stopped wearing sandals this summer because your toenails are damaged or just plain ugly, a local foot doctor says he can help you. He says he can painlessly replace your nail in minutes. During the sizzle of summer, women can't wait to expose their toes. Strappy, sexy sandals are a must for many, unless you're like medical assistant Donna Luther.
I wear closed-in shoes instead of sandals in the summer.
Donna stopped wearing sandals and painting her pinkies years ago after dropping something on her toe, damaging the nail.
It's just, you know, ugly.
Donna decided to restore her toenail with a new procedure called Cariflex. It's brand new and done by the foot doctor she works for. Donna says it was a patient who convinced her.
She loved it. She just couldn't believe, that something like this is possible.
Podiatrist Stephen Monaco says he can replace toenails that are broken or destroyed by fungus, taking them from this to this.
We're putting it over deformed nails or diseased nails, and because of that, it needs to be medically applied, and that's where the difference between us and a salon comes in.
Dr. Monaco removes the damaged part of the nail, treats any fungus, then builds a new nail right into the nail bed. It's dried by ultraviolet light. Donna's new toe is ready in about 15 minutes.
It is magnificent.
Remember what it looked like before?
Oh, it's beautiful.
It's a flexible polymer. It's not rigid acrylic, so that the material stays on the nail better. It adheres better. It doesn't pop off. It's flexible. It moves with the nail.
It'll need occasional touch-ups as the real nail grows back. Dr. Monaco says he's treated grateful women and men.
Some of them have always almost been to the point of tears because they're so glad that they have a normal-looking nail again.
You gonna be wearing Sam?
It costs $150 for up to 5 nails, and it's not covered by insurance. Toenails can be painted immediately, and remover will not harm the new nail. There are no known side effects, and the doc says he can do fingernails as well.
The iCube station allows us to use the iCube scanner in 3 positions: to do a non-weight bearing scan, a semi-weight bearing scan, and a full weight bearing scan. But also allows us to scan a crush box and also a cast that comes from the practitioner. From non-weight bearing, we can also do semi-weight bearing scans by just deattaching the scanner and moving into the semi-weight bearing position. For the semi-weight bearing, the patient positions the foot on the scan, and the practitioner can align the foot and hold the foot in position, and simply click on the scan either left or right foot. The iCube scanner is going to take a 3D image of the foot and also a 2D picture of the foot to check for calluses and ulcers. So now we have the semi-weight bearing image of our patient's foot. It's clearly to see the calcaneal angle and etc. From semi-weight bearing, it's very easy to move the iCube scanner to a full weight bearing position. But just putting in position, our foot model will stand on the iCube stand, lay the foot in, and we can simply select to scan the left foot, and the iCube scanner is getting the 3D image of the foot. And now once the software creates the 3D image of the foot, we can evaluate and check. The doctor or the practitioner can click on the next icon to start aligning the foot to the ground and identify the first metatarsal head, the 5th metatarsal head, and the heel point that will be used at the lab to design the orthotic. So we can easily look at the foot from the back and make sure that the calcaneal angle is vertical by moving the points. We can also look at the foot from a plantar view to identify the first metatarsal head. By dragging and dropping these points, the iCube software will update that for you automatically, and you can have a plantar dorsiflex or a plantar flexed location. And then to finalize, we can select the apex of the arch or the highest point of the orthotic that the doctor can identify and the software measures in real time. Once we're happy with the alignments, we can proceed to the next step, which will be to order the type of orthotic and the shoe sizing and etc. On the left hand side, we have all the options that we can select. For example, the shoe grading, let's say US men's number 9. The activity level, if it's going to be 1, 2, 3, or 4, so rigid, semi-flexible, and flexible. The problems that the patients may have, such as heel pain, forefoot pain, plantar fasciitis, and etc. The patient's weight, and the shoe style depending on what shoe that manufacturer that we work with. Then we can proceed to the next step, which will be the orthotic types such as polypro, graphite, and as you can see here preloaded in the software we have quite few different orthotic types that are customizable as well. We're going to select the posting that we want, so the rear foot posting can be controlled independently from the forefoot posting. For example, we can add intrinsic varus, and add millimeters or degrees. And we can also add a valgus extrinsic posting on the rear foot posting as well. The corrections, if we're going to select an arch fill or a plantar facial groove, a curb skive, can all be selected by the doctor before the scan is sent to the lab. Additions, such as heel cushion, hole in heel like a heel spur, and etc. The top cover that we would like, a full top cover or 3/4, and the material together with its thickness. The delivery date, when this orthotic can be delivered, and more important notes that we'd like to enter. So the next step of the process, by using Ortho Manager, the practitioner or the doctor can send all this information to the lab, such as the 3D shape of the patient's foot, together with the picture and the prescription. So no longer we have to mail crush box or casts. Everything is sent by email, and the lab can automatically start manufacturing the orthotic. If you would like to find more information about our healthcare products, please visit www.delcam-healthcare.com.
Hi, my name is Philip Vasili. I'm an Australian podiatrist and I've been in practice for over 25 years. Now I'm going to talk to you a little bit about orthotic technology, how these devices work, more importantly, how can they treat the common aches and pains that we suffer from heel pain, knee pain, and even back pain. Now as a podiatrist specialising in biomechanics, I've learned to understand how important the human foot is. We take between 5,000 to 8,000 footsteps per day on a very small unit which contains 26 to 28 bones per foot. So it is important that the foot is working correctly to prevent many of these common aches and pains that we do suffer from every day. When walking, our feet are the only interface with the ground. When we look at how the forces of walking can lead to common aches and pains, such as pain under the heel, pain at the back of the heel, and knee pain, one movement we are very interested in is called pronation. Pronation is the normal part of walking that happens every time we take a step. It is the movement that occurs during the period from the heel hitting the ground to the foot being flat on the ground. Now I'm going to talk to you about excess pronation, firstly what it is, and secondly how it affects the human body, from the foot through to the knee and even to the back. As you can see with Lauren, I've drawn a dot on her knee and also a dotted line down the front of her leg through to her ankle and to her second toe. If you look at this line, you'll see a curvature inwards. This is called excess pronation and it affects the majority of the population. Now this occurs because we're walking on hard, flat surfaces which causes our feet to roll over and our arches to collapse. Now as a podiatrist, what I want to see with Lauren's foot is this posture. As you can see, the arch rises, the knee realigns, and this line becomes a lot more straight. Now if Lauren holds it there, that looks correct, and it is correct. Now if I let Lauren relax her body, you'll see that her body rolls over. This is called the excess pronation. We get the rotation of the leg, which affects the knee, and also the muscles in the leg pull, and the feet collapses. Now this causes many aches and pains, much like bad wheel alignment on a car. It runs right from your foot, through to your shins, into your knee, and up to your back. So how can orthotic technology help? Our orthotic technology is shown to reduce overpronation, which can cause problems such as heel pain, knee pain, and even back pain. Now if we look at the line on Lauren's leg, you'll see it curved inwards. This is what we call excess pronation. Now if I place the orthotic device under her foot, which runs from her heel up through her arch to her forefoot, look at the difference. Very dramatic improvement of the line of the knee, through to the shin, the ankle and the forefoot. Even the height of her arch is improved. Again, if I take it out, watch the difference. Lauren's foot pronates again, which rolls in, causing the arch to collapse, the leg to rotate inwards, which strains the musculature here, rotates the knee, commonly causing knee pain and even affecting the back. Once more, we're going to show the correction with the orthotic device. And here we can see the perfect alignment of the knee, the shin, and even the foot. This technology is available in all of our orthotic products, and it is built right into our footwear range. Tight aching legs is very, very common, and a lot of times I would have patients come to see me for totally different conditions, whether it was heel pain or knee pain. But at the same time I used myorthotic therapy, they would come back and say, wow, my aching legs has diminished or completely gone. And I'd say, well, you didn't mention the tight aching legs before. And generally they say, well, I didn't know I had tight aching legs. I thought it was normal. Exactly, I thought it was normal. So what we find is we all know the musculature at the back of your legs runs into your foot. And your foot, as I explained, is made up of many bones, and about 25% of all the bones in your body are in your feet. Now, the hard, flat ground creates this excess pronatory factor. So as the foot pronates, you get a tractioning right down the leg of all the musculature. So imagine this is the heel, this is the arch, and this is the forefoot. Your foot hits the hard, flat ground, and you pronate, which is the same mechanism as this. It tractions all the muscles down the back of your leg. Now, to patients, a lot of times I say, listen, I'll demonstrate this simply. Just get your hand, I say straighten your arm and pull your hand back. And imagine this is a foot. I say, where do you feel the strain? And they say, up here, in the arm. I said, right, it's the same as the leg. So the foot must be stabilised by using an orthotic device, reducing the excess pronation and the frontal plane motion of the calcaneus, and then you take a massive amount of strain off the posterior musculature, and in an event, the pains go.
So it's a little bit like balancing the wheels on your car.
Exactly. It's much like a wheel alignment. That's what an orthotic is. It's a natural product, in my opinion, as far as what it does do. And again, it allows the foot to function in more of a correct motion and increasing its frontal plane motion, which causes the common pains here. With patients who suffer from tight aching legs or increased sensations that run down the posterior crural region, you find that there's a common association with the hard, flat ground and excess pronation, which is this angle here. If we re-correct the foot to the neutral position, you'll see an incredible rise in the arch, and that's due to the mid-tarsal region locking and going back to its natural position. But more importantly, you've taken off this strain from this posterior crural group. Now let the foot relax. You'll see the foot pronates, the arch collapses out, and you've physically strained all the soft tissue area here, and that causes many of the aches and pains that people suffer from on a daily basis.
Flip-flops. They're the summer sandal I know so many of you can't live without. They're cheap and they're easy. But what you may not realize is they could actually be harming your feet. Today, you'll find out the truth behind flip-flops and which ones you ought to be wearing. But first, I want you to meet Renee, a self-proclaimed flip-flop addict.
Dr. Oz, I live in my flip-flops. I have so many pairs that I've lost count. I wear them everywhere. I wear my favorite pairs until they're completely worn down. I love them, but could they be bad for my feet?
Renee is here, and she has brought her entire flip-flop collection. Is that it? You want to show it to us?
This is it. This is all of them.
That is a lot of flip-flops. So you must love these a lot.
Yes, they're so comfortable. They match everything. They're cheap. Why not?
You love them more than shoes, I can see. You own shoes also?
They're my backup shoes. I do have regular shoes, but they're my go-to.
So these may look comfortable, and I agree they are easy, but let's look at a closer view, if I can, with you.
Okay.
Come back over here a second. This is what a typical flip-flop looks like to me. And these are the concerns that I have. You notice there are two thin straps here. You notice it's pretty thin in its sole, and there is no arch support. That's the trifecta of problems for me. And so when I see those three things, I start worrying about a couple issues regarding to our feet. The first problem is pretty simple. There's no hard sole, and it's thin, so if you walk along, and I don't know where you live, but around where I live, we see construction sites once in a while, and you step on anything sharp, that happens. So this is just the beginning. But I'm even much more worried about flip-flops and how they change the way we walk, because actually there's a significant event that occurs. Let me show you, if I can, how I look at a foot as a physician. Okay? Notice how many bones there are in the feet, right? And when you got a dozen bones and structures that hold them together, you realize that you have to be able to manage them the right way. Now, normally when you walk, your foot has a little bit of an arch to it. Okay? Notice that? Yes. And you see this little red thing here? That's the plantar fascia. So it actually has the ability to stay limber and loose as you walk. When you're actually on a flat surface, in particular if you're wearing flip-flops, it tautes out the muscles. So can you see how it gets that plantar fascia really tight?
I can see that.
And as that gets tight, so it goes from a nice loose setting, when you're in regular shoes with little arch support, to a very taut setting, you start having little micro tears, little irritations right in this part of the foot, the back of the foot, close to where the tendon attaches. And that irritation is called plantar fasciitis. I suspect you've heard of that.
Yes, I have.
You see that little ridge there? Can you all see that in the tight camera? See that little ridge right there? Little catching area? So go ahead and feel that with your finger. That's called a heel spur. Let me show you an x-ray what happens. This is actually of someone's foot who had plantar fasciitis. See the spur here? When you have repeated trauma there, calcium deposits there, and that little spike there then digs into your tissue. Ugh, it feels painful, doesn't it? Just the thought of it?
It's like a nail in your bone.
Yes, it's like a nail in your bone. And that causes repeated irritation of the plantar fascia. That makes it worse every time you tap. So when you first get out of bed, even when you're not wearing those shoes, even when you're wearing the right kinds of shoes, it becomes a problem. It literally feels like this nail going through your foot, except there's no nail there. So it's harder for us to deal with that. All right. So can I give you some good news for a change? Now,
Yes,
that hopefully scared you a little bit. The good news is if you're walking around in high heels all the time, you don't have to give up your flip-flops. It's actually been shown to be beneficial when you get home to be able to walk in flip-flops because they take some of the tension off your knees. Okay. The other thing is that by walking in the right kinds of flip-flops, you can avoid all those headaches. So I'm going to give you a quick primer on this. Okay? The first thing you want to do is avoid those really thin soles. So get a little bit of a thicker sole, a little bit of a cushioned sole. You don't want the heel to be more than 2 inches tall. So this is about 1.5 inches. And if you do it that in a smart fashion, you'll actually have a little bit of protection from the external environment, from infections and from trauma, from nails and the like. The other thing is you want to make sure that you have a little bit of arch support. Do you notice there's a little bit of a cushion here?
Yeah, it goes up a little bit.
Right, and that going up area, this area right in here, allows you to take the tension off that plantar fascia so you don't get those spurs I spoke of. Okay, the last little thing is, you see this thong here? I want you to get a thicker, wider thong.
Okay.
The very thin ones put a lot of pressure on your toes, and your toes sort of knurl up like this. If you get a thicker area, it diffuses the pressure over the top of the foot. They can be bought in many different brands. There's a brand called Ortho Heels now that makes medically sound versions of these. There are other ones as well. Find one that works for you and adopt that and add that to your collection over there.
Okay, I will.
Good.
Now that I know.
Bargain?
Thank you very much.
Thank you very much. Good luck with your flip-flop.
If you're referring to ball or foot pain, which we can see in this area marked with this arrow in the redness area, commonly what you get is a person comes to you as a patient saying, I complain of a hot area underneath the ball of my foot, or even a high area of weight. The other thing people have is a callus and a buildup of tissue there, and sometimes they come to a practitioner to have it removed, but it obviously comes back again. So if we have a look at the human foot, the thing that we notice in the same region is we have this area of pain underneath the metatarsal heads, but the longest bone is the second metatarsal. Now what happens when we suffer from excess pronation, and we relate that back to nature versus civilization concept, the metatarsal area becomes hypermobile, and we get a collapsing of the mid-tarsal arch area as well as the metatarsals. Now when you get that occurring, the second metatarsal becomes very loaded underneath the plantar surface. You get simply an increase of pressure, you get inflammation, and as a compensatory measure, callus builds up to preserve the soft tissue. The problem is, you're not treating the cause, you're treating the symptom.
So this condition is commonly called metatarsalgia, and it occurs also a lot in women who wear high heel shoes, is that right?
True.
Is that the same thing?
Exactly. A person who has metatarsalgia can get it by walking on flat ground, but obviously if you're going to load the front of your foot when you go up on a high heel, you're going to get more pressure. So generally women will suffer from metatarsalgia more than men due to the fact that they wear higher shoes. But the same instance, once you've got this biomechanical problem of excess pronation and you come to flat ground, you're still going to have the same problem. So that's why I would advocate orthotics in that particular case.
So it's essentially friction and pressure caused by poor alignment.
Exactly. It's a plantar flexion, a splaying, hypermobility of the forefoot. The second metatarsal is the longest, and when all the weight of your body goes on it, you get inflammation, weight, and as a compensation, callus build-up.
And what about corns and calluses? How does excess pronation contribute to corns and calluses on the foot? Okay,
that's a good question too. Corns and calluses, a lot of people think, well, my shoes are tight and therefore rubbing and I get corns and calluses. Now, most intelligent people shouldn't be buying tight shoes, and there are many people who have perfectly good shoes and still get corns and calluses. What happens is when the metatarsals become hypermobile due to the excess pronation, the forefoot splays and plantar flexes. And what happens, as a compensation, the digits start to come up and then they curl at the tip, which is kind of like the same effect as a scoliosis in the back, but we're getting this curvature in the foot. And when these toes become clawed, as one would say, you get friction on the tops of the toes, on the base of the toes, and again you get callus as a compensation.
Now, another common site for callus build-up on the foot I've noticed and we've discussed is this medial side of the big toe, the fat pad and the heel.
Exactly. I think I'll just explain how that occurs. Again, it's excess pronation due to the hard flat ground that we walk on, but if we imagine that this is a heel and this is an arch and this is a foot, when the ground is hard and flat, it causes our foot to pronate, and if you rotate the foot in, you get a lot of pressure on the inside area of the big toe. Pressure means callus. Callus can give you pain, and this whole cycle of abnormal forces on one area causes the problem. And again, the use of an orthotic to realign the foot takes the pressure off that area, and more importantly, distributes the weight equally across the 5 metatarsal heads. There's a common misdiagnosis between metatarsalgia and the condition we call Morton's neuroma, or I like to call it Morton's neuritis. As we see in this area here, it occurs basically in the same region as metatarsalgia, so a lot of people think that it's the same diagnosis. But what happens generally, if we look at a foot, we have a lot of nerves run into the foot, but at the base of the foot we have a medial plantar branch, a lateral plantar branch, and there is a conjunction between the third and the fourth in the plantar area, which is in this area, but at the base. Now when you pronate excessively and your forefoot becomes hypermobile, you get the metatarsals splaying and moving a lot in the transverse plane, which is this plane here. Now this nerve tends to become impinged or pinched, and over time it becomes larger, and there's a fibrous tissue builds up around this nerve. Then you get this enlargement, and one of the tests can feel this. The pain can feel the same, but generally people sort of say, I feel like a nerve sensation or an electrical shock running down my toe. Okay. A lot of times they can't figure out whether it's a third or the fourth, but generally you'll find in many patients they may exhibit a numbness in the toe, generally the fourth. But one way to test it is a very old technique but very effective, is the crunch test. If there's an enlargement of the nerve here, and I simply get my hand and I squeeze the bones together, the patient will jump through the roof because it's impinging that nerve. Okay. And normally they'll also feel the numbness. Sometimes I've even seen the fourth toe blue. It's affected the circulation, and overall the treatment's the same. We use a metatarsal raise in the forefoot to give integrity to the forefoot, but more importantly we come back to the rear foot with an orthotic to control the mid-tarsal joint and the rear foot, because the whole foot works as one. So controlling one bone is not as effective as controlling the whole of the foot.
Okay, great, thanks.
Commonly when people suffer from ball of foot pain, they get an increased pressure, and also you can see here a build-up of callus in this particular area. And what happens is these bones tend to sort of drop in a downward position this way, and you can see the toes come up here, and then the tips of the toes come down this opposite direction. So what we find is that with a correction using an orthotic with a lift in the metatarsal area, we raise this area here, we take the pressure off the front of the foot, at the same time the toes become straighter. So when you drop the foot, the pressure builds up callus, the callus causes pain, and at the same time you develop this curling of the toes, which causes corns on the tips of the toes. So again, if we push up underneath this area, we reduce pressure on the forefoot, and again the toes are straight, they don't rub on the shoes, and no rubbing, you get no friction, you get no callus or corns.
Lower limb biomechanics. The key to lower limb biomechanics is that to understand and treat faulty foot function, we must first understand normal foot function. The human foot is a complex structure of bones, joints, muscles and ligaments. The foot can be divided into three sections: the forefoot, the midfoot and the rear foot. The forefoot comprises the first to fifth metatarsal bones and phalanges. The midfoot comprises of the navicular and the cuboid, plus the medial, intermediate and lateral cuneiforms. The rear foot is made up of the calcaneus and talus. The subtalar joint. The main joint of concern in foot biomechanics is the subtalar joint, which is the joint between the calcaneus or heel bone and the talus. The proper function of this joint is crucial to a correct and pain-free gait. Motion of the rear foot. Triplane motion is the movement of the foot through three planes, i.e. three-dimensional. Sagittal plane, dorsiflexion and plantarflexion, frontal plane, inversion and eversion, transverse plane, adduction and abduction.
To understand the biomechanics of the foot and motion of the foot, we must firstly understand motion in the three cardinal planes, being the sagittal plane, the frontal plane, and the transverse plane. Now, to give you an example of motion in the sagittal plane, which is in this direction, we commonly get motion which we call dorsiflexion and plantarflexion of the foot. This upwards and downwards movement is motion in the sagittal plane. Now next we can talk about motion in the frontal plane, which is in this direction, and that's more when we get inversion and eversion of the foot. It's movement in the frontal plane, moving inwards and outwards of the foot. Now the last plane is called the transverse plane, which runs in this direction here. Now in that particular case we get more of a adduction, or moving towards the center of the body, and abduction, moving away from the body. Conversely, you can talk about internal rotation and external rotation of the upper leg as well, and that's motion in the transverse plane.
Range of motion. Motion at the subtalar joint is normally 2/3 supination and 1/3 pronation. Both pronation and supination are triplanar motions comprised of the following elements: pronation, eversion, abduction and dorsiflexion, supination, inversion, adduction and plantarflexion. The gait cycle. A prerequisite to understanding the role of the rear foot in gait is to understand gait. The gait cycle can be divided into two major phases: stance, when the foot is in contact with the ground, and swing, when the foot is not in contact with the ground. The pathologies we see develop because of foot dysfunction during the stance phase. The major functional phases of the stance phase of gait are as follows. The contact phase. The contact phase begins with the heel strike on the outside edge of the heel. The tibia internally rotates and the foot pronates at the subtalar joint throughout the contact phase. The contact phase is designed to convert the foot into a mobile adapter and shock-absorbing mechanism. The contact phase ends when the entire plantar surface of the foot is in contact with the ground. The mid-stance phase. The mid-stance phase begins when the entire foot is flat on the ground and continues until the heel lifts off the ground again. During this phase, we need a stable but flexible platform from which to support the body. The mid-stance phase converts the foot from a mobile adapter into a rigid lever. During this phase, the tibia externally rotates and the foot supinates at the subtalar joint, preparing the foot for propulsive phase. The propulsive phase. The propulsive phase begins when the heel lifts off the ground and continues until the apex of the hallux leaves the ground. Just prior to heel lift, the subtalar joint should approach the neutral position, whereby the forefoot and rear foot lock together to enable effective toe-off. The foot continues to supinate during toe-off with external tibial rotation. In propulsion, the limb is extended and can efficiently channel load to create forward motion. Rear foot function, Part 1, the ankle joint. There are two major joints in the rear foot. The first is the ankle. This video shows ankle joint function during the stance phase of gait. During the course of any step, the center of body mass must pass from behind the weight-bearing foot to in front of it. Ankle joint motion is very important during gait, and when we view subjects walking from the side, we can see these motions very clearly. Rear foot function, Part 2, the subtalar joint. The second major joint of concern is the subtalar joint. The terms pronation and supination are used to describe the motions taking place at the subtalar joint. It is important to focus on the motion that can be seen in the calcaneus with subtalar joint motion. In the photo on the left, the calcaneus is inverting, which indicates that the subtalar joint is supinating. In the photo on the right, the calcaneus is everting, which indicates that the subtalar joint is pronating. Inversion and eversion take place in the frontal plane and indicate only one component of subtalar joint motion, the normal lower limb and tibial verum factor. The normal lower limb is inverted approximately 4 degrees from the vertical. This is called a tibial verum and influences normal subtalar joint function. Tibial verum angle varies between individuals. Excess compensatory pronation. The tibial verum factor, combined with the hard, flat, unnatural surfaces we walk on daily, causes the feet to pronate excessively. The most common form of lower limb biomechanical dysfunction is excess pronation. Excess pronation at the subtalar joint commonly exhibits calcaneal eversion. Internal tibial rotation. Lowering and elongation of the arch structure. Excess weight bearing over the first metatarsophalangeal joint. Excess medial lower limb strain. During the mid-stance phase, the foot remains pronated and unlocked instead of re-supinating to a locked position, turning the foot into a rigid lever. The effect of excess pronation. The subtalar joint axis lies approximately halfway between the frontal and transverse planes, about 42 degrees in the sagittal plane. Therefore, for each degree of calcaneal eversion, frontal plane motion, we see an equal degree of internal tibial rotation, transverse plane motion. This is the all-important link between lower limb biomechanical function and upper body posture. The function of the subtalar joint. The importance of the subtalar joint arises from its unique orientation, which allows it to convert foot rotation into leg rotation and leg rotation into foot rotation. An example is the differential in the car. It rotates on one plane, but converts motion into another plane sitting at a 90-degree angle. The subtalar joint can be thought of as a torque converter that converts limb rotations into foot motion and vice versa. The ideal lower limb. The ideal lower limb exhibits the following characteristics. A. Bisection of the lower 1/3 of the tibia is vertical. B. The knee, ankle and subtalar joint lie in transverse plane parallel to the supporting surface. C. The subtalar joint rests at neutral, i.e. no supination or pronation. D. The bisection of the calcaneus is vertical. E. The mid-tarsal joint is locked, maximally pronated, and the forefoot plantar plane aligns the rear foot plantar plane. Footprints. Footprints in the sand show us a couple of interesting features. 1. Lateral strike. The footprint reflects the inverted heel strike pattern by having a deeper lateral indentation. 2. The footprints walk to a center line, which effectively increases our functional strike angle. On hard surfaces, this means the foot has to pronate further to gain ground contact. Pronation. Internal changes. The changes that are visible externally occur as a result of changes to the internal bony architecture. On the left is a supinated foot. The navicular on the medial aspect of the foot is higher than the calcaneus. The talus is adducting and dorsiflexing with supination. The photo on the right shows a pronated foot with the talus abducting and plantarflexing. These are the normal motions that occur with pronation and supination. The width of the foot changes between supination and pronation. The pronated foot is wider, and we can see that the navicular lies more medial than normal. This in itself can be a problem and can cause the bulge in the medial aspect of footwear that is often seen in patients with an excessively pronated foot, prominent navicular. Our feet were originally designed to walk on soft, natural surfaces like earth and sand. But unfortunately, we now spend most of the day walking on hard, flat surfaces like pavements and floors. The normal lower limb is represented by a 4-degree tibial varum angle. The lower limb forms a natural inverted position to the ground, and therefore when the foot strikes the ground, the outside edge of the heel hits the ground first. When the foot strikes a soft natural surface like sand, it will give way to accommodate the foot's strike angle, forming a natural footprint. However, when approaching hard, flat ground, the foot must compensate by pronating excessively at the subtalar joint to gain ground contact. Therefore, the greatest cause of excess pronation is our natural tibial varum angle, combined with unnatural hard, flat surfaces we walk on. Excess pronation causes a chain reaction throughout the body. As the feet pronate, the tibia internally rotate and the pelvis is tilted forward. In turn, excess pronation can cause a range of aches, pains and injuries.
Okay, as you can see here, this foot is standing on hard, flat, unnatural surfaces. This is concrete and it's very hard. And as you can see, what the concrete or the hard floor forces the foot to do is to roll inwards. Now this motion or angle here, which is going inwards and flattening the arch, is called excess pronation. If this person was standing on soft natural soils, grass or sand, the foot would actually be standing in this position. And as you can see, if we twist the foot to its natural position, you get the increase in the arch height, you get the alignment of the knee with the foot, and you have a better overall bone structure in the whole foot and leg structure. Now if the foot relaxes now, you'll see how the foot rolls back in due to the hard flat ground, and this is the common problem that causes these aches and pains in our foot, which are metatarsalgia, ball of foot pain. You can see the rolling inwards here puts a lot of pressure on the big toe, which causes bunions. You get clawing of these toes where you get the corns and calluses. And more importantly, the common cause of this flat-footed appearance occurs here because the foot moves from this position where there's a good arch, it rolls in under excess pronation, collapses the arch area, and you get this flat-footed appearance, which also puts strain on the heel, causing the heel pain, plantar fasciitis, also rotating right up the leg into the knee. The knee in this case is pointing this direction, the foot is going in this direction. If the foot was in neutral position or stance, the knee would follow the foot. Unfortunately, when the foot pronates excessively, we get this rotation of the knee, which causes knee pain, and conversely, right up the whole body, we get this rotation, which is the common cause of lower back pain. Lower back pain, and again, let me say this. I'm talking about pain in your lower back that has not come from a injury or a herniated disc or a spondylolisthesis or some condition that is medically not connected to the biomechanics of the foot and lower foundation structure. I'm talking about back pain, and there's been a lot of research done in the last few years showing that the hard, flat ground we walk on causes our feet to pronate and collapse. And when your feet pronate and collapse, your knees internally rotate, which I'll show you on our physical model shortly, which causes a rotation or tilt in our pelvis. Now, a lot of people will say, I've got a dull ache in the lower part of my back, and you know, I may have been to a physiotherapist, and the physiotherapist said, well, listen, go and strengthen your stomach muscles. Strengthen those muscles because it'll take the pressure off your back. I say this, it's good to strengthen your stomach muscles, and a lot of times they do need strengthening, but why are they weak in the first place? And why are the muscles in your back tighter, and why is this imbalance occurring? Let's not say you've got a tight muscle here and a weak muscle there and just balance them up. Let's ask ourselves, why are they like that? Generally, the reason is because we have a mechanical problem occurring which makes one muscle stronger and one muscle weaker. Now, you know this from going to the gymnasium. How many times have you been to a gym and the exercise instructor there says, if you want to do this exercise properly, do it this way? What is he saying? Unless your bones are working in the correct posture, you're working the muscles incorrectly so that you will cause an imbalance and possible injury. Now, in lower back pain, I have made so many orthotics, like I've lost count, to be honest. And when I first started making orthotics, I didn't treat back pain. I treated the feet. But everybody would come back to me and say, you know, Phil, my back is so much better. And after sort of doing so much work with the foot, I made it a point in my own head is to find out how do orthotics, and particular orthoheel, help with low back pain. So let's just go to our foot model and I'll show you a physical example of how this can occur. When looking at back pain, the most common area of back pain is in this low lumbosacral area here. And commonly it's not caused by an injury or an accident, as in certain cases. We're talking about low back pain and tightness due to simply poor posture of the lower leg, which affects the knee and the hip and therefore the whole pelvic girdle. Many times, as I said, the pelvis becomes loose, and as the feet roll inwards, it tilts the pelvis forward, which increases the curvature of the lower back, causing pain. Now, if Lauren wears orthotics or orthoheel, we twist the feet out, it pulls the stomach area in, reduces the curvature of the back, and therefore balances up this lower area of her abdomen and back, removing this common cause of lower back pain.
Phil, I understand heel pain is the #1 foot pathology. Specifically, you're going to tell us a little bit about plantar fasciitis.
Yes, that's correct, Bruce. If we look at this picture here, we'll see the common area of pain is underneath the base of the heel. And the common term medically is plantar fasciitis, which means inflammation of the plantar fascia, but more at the base or the origin of it. What patients normally complain of is a pain that initially can occur on rising, whether it's getting out of bed in the morning or sitting down for a long period of time, then standing up quickly. What happens is they get a sharp, piercing pain underneath the base of the heel, much like a stone bruise. They tend to hobble around for a few minutes and then the pain seems to disperse and go away. However, if they sit down or lie down, the next morning it occurs again. Now what happens here, I say to a lot of people, when you're in bed lying down, your foot is actually in a relaxed position. Your arch has no strain on it, and we all know medically that the plantar fascia runs from the base of the calcaneus, the tibial tubercle, runs up to the forefoot and splits into the 5 metatarsal areas like this. Now if you're in bed like this, the plantar fascia is much like a bowstring. There's your bow, and the fascia forms the bowstring. As soon as you get up in the morning, you put all your weight on your foot tends to pronate excessively due to the nature versus civilization aspect, and when you collapse the mid-tarsal area due to excess pronation, it creates a massive force over the origin of the plantar fascia. If you look at the foot, you'll see most of the weight runs over this rear section, so you get the detachment at the heel, not in the middle of the foot or in the front of the foot.
Attractional force you're talking about.
Exactly. So you sit down, your foot is relaxed, you stand up, bang. And the trick is here, is when you stand up in the morning or you get out of bed, I caution patients to get out of bed very slowly, because as soon as you get that pain, you've ruptured microscopically the plantar fascia. You get bleeding into that area, and then later on, you're not breaking the cycle. So what I advise is the use of an orthotic, or even better, a sandal beside the bed, an orthoheel sandal, say, or some product that is orthotic in respect, so that you don't get out, collapse the foot and create that chain reaction day by day.